Good day, dear doctors. Today we have first lecture from the group of lecture by chapter Typical Pathological Process. The name of our lecture is Carbohydrate Metabolic Disorders. Carbohydrate metabolism plays a vital role in cellular function by providing the energy required for the most metabolic processes. Glucose is the principal substance of energy metabolism in human body. Metabolism of glucose generates ATP via glycolysis and mitochondrial oxidative phosphorylation. In humans, blood glucose is strictly regulated by a hemostatic mechanism and maintained with a narrow range. A balance is preserved between the entry of glucose into the circulation from the liver, supplemented by intestinal absorption after meals, and glucose uptake by peripheral tissue, particularly by skeletal muscle. When intestinal glucose absorption declines between meals, hepatic glucose output is increased in response to low insulin levels and increased level of the counter-regulatory hormones like glucagon and adrenaline. The liver produces glucose by gluconeogenesis and glycogen breakdown. After meals, blood insulin levels rise. Insulin, like you know, is an anabolic hormone with profound effect on the metabolism of carbohydrate, fat and protein tissue. Insulin is secreted from the pancreatic beta islet into the portal circulation with a brisk increase in response to a rise into blood glucose. Insulin lowers blood glucose by suppressing hepatic glucose production and by stimulation of glucose uptake in skeletal muscle and fat tissue, mediated by the glucose transporter. Dietary sources of glucose are obtained by ingesting polysaccharides, primary starch and disaccharides including lactose, maltose and saccharose. Galactose is derived from the lactose. It's galactose plus glucose, which is found in milk products and is an important component for certain glycolipids, glycoproteins and glycosaminoglycans. The two dietary sources of fructose are saccharose, fructose plus glucose, are commonly used sweeteners, and fructose itself, which is found in fruits, vegetables and honey. Glycogen is a storage form of glucose in animal tissue, animal cells. Defects in glycogen metabolism typically cause in accumulation of glycogen in the tissue, hence the name glycogen storage disease. By clinical manifestation of the various disorders of carbohydrate metabolism differ markedly. The symptoms range from the harm self to lethal. Unlike disorders of lipid metabolism, mucopolysaccharides, or other storage disease, dietary therapy has been effective in many of these pathologies. Diabetes mellitus clinical syndrome, which is characterized by hyperglycemia due to the absolute or relative deficiency of insulin in our body. This can arise in many different ways, but is the most common due to the autoimmune type in first diabetes mellitus or adult onset form in second type of diabetes mellitus. Several distinct types of diabetes mellitus exist and they are caused by the complex interaction of genetic and different environmental factors. Depending the etiology of the diabetes mellitus, factors are contributing to hyperglycemia include reduced insulin secretion, decreased glucose utilization, and increased glucose production. The metabolic dysregulation, probably associated with diabetes mellitus, caused by secondary pathophysiological changes in the multiple organs and systems. And during the diabetes mellitus, these disorders of organs as systems are subdivided into the main groups. It can be micro and macroangiopathy. When we talk about microangiopathy, it will be group disease which are subdivided on the three types. It can be retinopathy, nephropathy and neuropathy. When we talk about macroangiopathy, this group are complete pathology of big elastic vessels like coronary vessels, cerebral vessels and else. Insulin is produced in beta cells of the pancreatic island. Glucose is a key regulator of insulin secretion by the pancreatic beta cells. Also, amino acid, ketones, various nutrients, gastrointestinal peptides, and nitrosamine transmitters also influence insulin secretion. Glucose level over than 3.9 millimole per liter stimulate insulin synthesis, primarily by the unchanging protein transportation and proceeding. Glucose stimulation of insulin secretion begins with its transport into the beta cells by the glutathione to glucose transporter. Glucose phosphorylation by glycokinase is a rate-limited step that controls glucose-regulated insulin secretion. Once insulin is secreted into the portal venous system, and near the 50% is degraded by the liver tissue. Unextracted insulin enters in the systemic circulation blood, where it binds to receptors in target cells. Insulin binding into these receptors stimulate interesting tyrosine kinase activity receptors. After phosphorylation and the requirement of intracellular signaling molecules, insulin receptor substances. Insulin receptor substrates and other adductors proteins initiate a complex cascade of phosphorylation and dephosphorylation reaction, resulting in the widespread metabolic and mitogenic effects of insulin. Elevated concentration of glucose in blood stimulates release of insulin, and insulin acts on cells throughout the body to stimulate uptake, utilization and storage of glucose. The effects of insulin on glucose metabolism vary depending on the target tissue. We have two the main effects in this situation. First one is insulin facilitates entry of glucose into muscle, adipose and several other tissue. The only mechanism by which cells can take up glucose is by facilitated diffusion through a family of hexose transporters. Second one is insulin stimulates the liver to store glucose into the form of glycogen. A large fraction of glucose absorbed from the small intestine and immediately taken up by hepatocytes in liver, which convert it into the storage polymer glycogen. We have the least functions which are typical for insulin. In addition to its role as regulation of glucose metabolism in our body, but we also have another functions of this hormone. It stimulation of lipogenesis, diminish of lipolysis, increase amino acid transport into the cells, modulates transcription, stimulates growth of body DNA synthesis, and affects cells replication. Diabetes mellitus is classified into the basic of the pathogenic processes that leads to hyperglycemia as opposed to earlier criteria such like age of onset of type of therapy. The two broad categories of diabetes mellitus is designated by the first and second type of diabetes mellitus. When we talk about first type, it's probably immune-mediated form of pathology and with idiopathic predisposition. When we talk about second form and other specific type of diabetes mellitus, it can be genetic defects, beta cells function, can be genetic defect of insulin action, can complete pancreatic disease which can lead to insufficiency of beta isolate like pancreatitis, pancreatectomy, neoplastic pancreas disease, cystic fibrosis, hemochromatosis, and fibrocarcinosis of pancreatopathy. Excess endogenous production of hormonal antagonists to insulin, like growth hormones in acromegaly, excessive production of glucocorticoids in Cushing syndrome, excessive synthesis glucagon by glucagonoma, excessive production catecholamines in pheochromocytoma, and excessive amount of steroid hormones in thyrotoxicosis. And next one, reasons, it can be drugs-induced abuse, it can be use of corticosteroids, thiazine diuretics, and phenytoin. Also, viral infection can lead to insufficiency of beta isolate, like congenital rubella, mumps infection, Coxsackie viruses. Uncommon forms of immune-mediated diabetes. Diabetes associated with genetic syndrome, which is typical for Down syndrome, Klinefelter syndrome, Turner syndrome, person with Wildrow syndrome, diabetes insipidus, diabetes mellitus, with optic atrophy and nerve defense. And like individual form, it can be gestation form of diabetes mellitus in pregnant women. First type diabetes mellitus is the result of interaction of genetic, environmental, and immunological factors that ultimately lead to the destruction of the pancreatic beta isolate and insulin deficiency in our body. Results from autoimmune beta isolate destruction, and most but not all individuals have evidence of isolate directed autoimmunity. Some individuals who have the clinical phenotype of first type diabetes mellitus lack immunologic markers indicative of an immune process involving to the beta cells. Individuals with a genetic susceptibility have normal beta cells mass at birth, but begin to lose these beta cells secondary to the autoimmune destruction of the cells that occurs over the months to years. Family studies have produced by evidence that destruction of the insulin secreting cells, beta isolate, in the pancreas isolate take place over many years. Hyperglycemia accompanied by the classic symptoms of diabetes occur only when the 70-90% of beta isolate have been destroyed in patients. Islet cells antibodies can be detected before the clinical development of first type diabetes mellitus, have a variable predictable value as a marker of disease, and disappear with increased duration of diabetes. Genetic factors account for about 1/3 of the susceptibility to first type diabetes mellitus, the inheritance of which is probably polygenic. Over the 20 different regions of the human genome show some linkage with first type diabetes, but most interest has focused on the human leukocyte antigen region with the major histocompatibility complex on the short arm of 6 chromosome. Human leukocyte antigen haplotypes DR3 and DR4 are associated with increased susceptibility to type 1 diabetes in person in Caucasian mountains. The latter may be the main determinants of the genetic susceptibility, since these human leukocyte antibodies class 2 genes code for protein on the surface of cells, which present foreign and self-antigens to T lymphocytes. Defective presentation of autoantigens derived from the pancreas island beta cells probably underlies the development of autoimmunity. Numerous environmental events have been proposed to trigger factors that autoimmune process is genetically susceptible in individuals. Viruses like Coxsackie virus, rubella virus, mumps virus most prominently. Various nitrosaminoglycans found in smoke and cured meats and coffee have been proposed as potential diabetogenic toxins. Stress play a very important role, like factors which stimulate the secretion of counter-insulin hormones and possibly by the modulating immune activity in fast form. Patient with fast type diabetes mellitus present when its progressive beta cells destruction has crossed and threshold at which adequate insulin secretion and normal blood glucose level can no longer be sustained. High glucose level may be toxic to the remaining beta cells, so that profound insulin deficiency rapidly ensues. Hyperglycemia leads to glucoseuria and dehydration of this patient with first form of diabetes mellitus. Understrained lipolysis and proteolysis result in weight loss of patient and increased glycogenesis and ketogenesis in this patient. When generation of ketone bodies exceeds the capacity for their metabolism, ketoacidosis will be such as a result of this pathology. Patients usually present with quite short history. Typically, it's few weeks enough to development of fast manifestation. Hyperglycemic symptoms like thirst, polyuria, polydipsia, fatigue and polyphagia, fatigue and secondary infection typical for this patient. Typical, it's also loss of mass body for fast form of diabetes mellitus and may have development strong ketoacidosis and all complications which typical for this metabolic disorders. In second type of diabetes mellitus, we have some typical manifestation which characterized by impaired insulin secretion, insulin resistance and excessive hepatic glucose production with abnormal fat metabolism. For second type diabetes mellitus are typical obesity, particularly visceral or central type is very common. Insulin resistance appears to come first and leads to elevated insulin secretion in order to maintain normal blood glucose level. However, in susceptible individuals, the pancreatic beta island beta cells are unable to sustain the increased demand for insulin and a slowly progressive insulin deficiency development in this patient. Production of glucose in the liver and underutilization of glucose in skeletal muscles results from resistance to the action of insulin. A characteristic features of second type diabetes mellitus is that it is often associated with other medical disorders, particularly central or visceral obesity, hypertension and dyslipidemia. Adipose tissue relies a number of hormones which act on the specific receptors to influence sensitivity to insulin in other tissue. Because visceral adipose tissue drains into the portal vein, central obesity may have a particularly potent influence on the insulin sensitivity to the liver, in the liver, and thereby adversely affect gluconeogenesis and hepatic lipid metabolism. Also typical for this patient, pancreatic beta cells failure. In the early stage of second type diabetes mellitus, there is only moderate reduction in the total mass of pancreatic islet tissue, while beta islet numbers are typically reduced by 20% in type of 2 diabetes mellitus. Alpha cells mass is unchanged and glucagon secretion is increased in this patient, which may contribute to the hyperglycemia. When we talk about genetic predisposition, second type diabetes mellitus has a strong genetic component. The concordance of second type is identical twins is between over than 70-90%. Individuals with a parent with second type diabetes mellitus have the terrible high risk development of this form diabetes mellitus. If both parents have type 2, the risk approaches in 40%. Type 2 diabetes mellitus also associated with overeating, and especially when combined with obesity and low physical activity in patient. The disease is polygenic and multifactorial signs in addition to genetic susceptibility. Environmental factors such as obesity, bad nutrition, junk food, and physical inactivity modulate the phenotype of this form diabetes mellitus. So the main risk factors in this pathology we should repeat. First of all, it's family history of diabetes, obesity, low physical activity, rice, it's probably African American, Latino, Native American, Asian American, and Pacific Island. History of diabetes mellitus or delivery of baby over 4 kilograms in mass. It's also high risk for the future generation. Hypertension, blood pressure over than 140/80, increase risk development of this pathology. High density lipoproteins level over than 35 milligram per deciliter, or triglyceride over than 250 milligram per deciliter, also increase risk to development second form of diabetes mellitus. Polycystic ovary syndrome and history of vascular disease, its factors which play very important role in risk development of this pathology. Age over than 35-40 years old, it's one of factors which increase risk development diabetes mellitus type 2. This form of diabetes mellitus is principally a disease of the middle age and elder person. Affects 10% of the population over than 65 years old, and over than 70% of all classes of diabetes occurs after the age of 50 years. About pregnancy. During the normal pregnancy, insulin sensitivity is reduced through the action of placental counter-insulin hormones, and this affects its glucose tolerance. The insulin secreting cells of the pancreatic islet may be unable to meet this increased demand in women genetically predisposition to development of gestation type diabetes. The term gestation diabetes refers to hyperglycemia occurring for the first time during the pregnancy. 80% of women with gestation type of diabetes mellitus ultimately development permanent type of diabetes when don't use preventive therapy. Patients with second type of diabetes mellitus have a slow onset of relative insulin deficiency. Glucosuria occurs when the blood glucose concentration exceeds the renal threshold, the capacity of renal tubules to reabsorb glucose from the glomerular filtrate at approximately near the 10 millimole per liter. The severity of the classical osmotic symptoms in diabetes mellitus, it will be polyuria. Polydipsia is related to degree of glucoseuria. In second type of diabetes, hyperglycemia develops slowly over months or years, and the renal threshold for glucose rise, so that osmotic symptoms are usually mild. In some patients with second type diabetes, presentation is late and pancreatic beta isolate function has declined to the point where there is profound insulin deficiency. A number of other metabolic abnormalities typical for second type diabetes mellitus, particularly complete dyslipidemia, are common in patients probably with second form. When we talk about acute complication of diabetes mellitus, we should remember about diabetic ketoacidosis. It's the one from main terrible manifestation and complication of this pathology. And they combine with hyperglycemic hyperosmolar state are acute complication. Ketoacidosis is a major medical emergency and remains as a serious cause of morbidity, principally in people with first type. Any form of stress, particularly that produced by infection, may precipitate severe ketoacidosis, and the patient with second form. The symptoms and physical signs of diabetic ketoacidosis usually develop over the first 24 hours. The cardinal biochemical features of diabetic ketoacidosis are complete: hyperglycemia, hyperketonemia, and metabolic acidosis. The hyperglycemia causes a profound osmotic diuresis, leading to dehydration of patient and electrolyte loss, particularly of sodium and potassium. Ketoacidosis, it results from insulin deficiency, accelerated by elevated catecholamines and other stress hormones, resulting in unrestrained lipolysis and supply of free fatty acid for hepatic ketoacidosis. When this exceeds the capacity to metabolize acid ketones, this can accumulate in blood. The resulting metabolic acidosis forces hydrogen ions into the cells, displacing potassium ions, which may be lost by urine or through the vomiting, which play the undivided symptom, which present like undivided symptom in ketoacidosis. Clinical manifestation of diabetic ketoacidosis complete: polyuria and thirst, loss of weight, strong weakness, nausea and vomiting, which lead also to hypohydration, leg cramps due to the loss of electrolytes, blurred vision due to the intoxication, and abdominal pain. Dehydration, hypotension, cold extremities with acrocyanosis, tachycardia, air hunger, which manifest by pathological or metabolic post-malarial respiration, smell of acetone from mouth and from urine. Sometimes in terrible situation we can feel the smell of acetone from the skin of body. Confusion, drowsiness, and like complication, coma, ketoacidic coma in this patient. Non-ketotic hyperosmolar diabetic coma. This condition is characterized by severe hyperglycemia over than 50 millimoles per liter without significant ketoacidosis or acidosis. Severe dehydration and prerenal uremia present in this patient. It usually affects elderly patients, many with previously undiagnosed diabetes mellitus, and morbidity of this patient it's very high, and complete over than 40% from all patients with hyperosmolar coma. The physician examination reflects profound dehydration and hyperosmolarity in this patient, and reveals hypotension, tachycardia, and altered mental status. Notably, absent are symptoms of nausea and vomiting because this patient don't have ketoacidosis. Also, you can find abdominal pain in this patient and pulmonary respiration, because all the symptoms are typical for acidic state of body. Relative insulin deficiency and inadequate fluid intake are the underlying causes of this type pathology. Insulin deficiency increases hepatic glucose production through glycogenolysis and gluconeogenesis, and impairs glucose utilization in skeletal muscle. Hyperglycemia induced an osmotic diuresis that leads to intravascular volume depletion, which is accelerated by inadequate fluid replacement in body. We have a list of chronic complications of diabetes mellitus. Can be divided into vascular and non-vascular complications. The vascular complications of diabetes mellitus are subdivided into microvasculopathy and macrovasculopathy. When we talk about microvascular disorders, it can be retinopathy, pathology of eyes vessels, neuropathy, pathology of peripheral neurons, and nephropathy, pathology of the tubular neurons. Macrovascular complication, it's pathology big elastic vessels, coronary arterial disease, peripheral arterial disease, and cerebrovascular disease. The risk of chronic complication are sharply increased as a function of the